Well, good afternoon, everyone. I'm very pleased to be able to present at this scientific convention. And I want to encourage you all to ask questions and to give me input at the end of this presentation. So in the midst of the pandemic, as a behavioral health professional, I thought that, wow, we should be looking at what are people doing regarding their behavior when it comes to transmission procedures to prevent contagion and prevent spread of infection. And I stated that, wow, when I looked into the literature, I did not see anything that was a useful clinical tool that could be used in inpatient and outpatient settings to assess for transmission-based precautions. So I developed the prototype, which is the transmission-based precaution inventory. And that's going to be the essence of my presentation. At the time and currently, it appeared to me that we will need a tool that can be objective and that could look at capacity to engage in transmission-based precautions for patients who are still infectious or who remain potentially infectious. And this tool can be used easily in different environments. It's an app-based tool which can be used on a tablet or on a iPhone or Android phone. The inventory itself is individually focused, and it's completed by the attending healthcare provider. So this could be the attending physician, potentially specialist, the nurse who's assigned to that patient, and it could be used in a collaborative way that several people could rate the patient. And I'm working on a way to conglomerate those ratings into one so that we can have a multiple rater form that could be even more powerful, because now we have several people rating this patient on specific items that, of course, I'll get into, that comprise this inventory. I'm from New York, so if I talk a little fast, please bear with me. And if you need me to slow down, somebody just raise your hand or ask me to slow down. Okay, patients in high-risk groups are particularly targeted by this inventory. So patients in residential settings, rehabilitation settings, and psychiatric settings would be considered high risk, although obviously there are other subgroups as well. And this tool is easy to use. So it's used at bedside, used at time of discharge, and can come up with the ratings that we're looking for. Even general medical patients who may be completely competent cognitively may have physical, psychophysiological, other needs that won't allow them to use TBI procedures. And it's important that we would know that they could not really participate in potentially putting on a face mask, for example, or washing their hands or other things that could help with mitigating infection. So even with patients that are not in high-risk groups, there may be people that do need to still be looked upon as high risk. And it can be implemented as a routine discharge procedure to assess transmission-based precaution behavior upon discharge. So part of the discharge process, the attending, the nurse, the social worker, somebody involved with that patient can use the tool to come up with a rating for how much risk does this patient have to transmit infection if they go back into another environment, particularly if it's a community environment or a setting where you have other high-risk individuals. High-risk groups, subgroup samples, obviously elderly patients, certainly with a previous diagnosis of mild cognitive impairment or dementia, and patients presenting to the emergency department with acute onset of delirium, even patients with UTI, patients with other infections can oftentimes be in a very compromised neuropsychiatric state. Patients with pre-existing neuropsychiatric conditions, mood disorders, psychotic disorders, etc., can present in a high-risk group. Patients with neurological conditions that involve cognitive symptoms may also be high risk, and patients with came into the hospital or facility without exhibiting neuropsychiatric or cognitive difficulties, but developed them during hospitalization, fall into the high-risk group as well. There was a study done back in 2020, it seems like it was just yesterday, which retrospectively reviewed elderly patients diagnosed with COVID-19 at that time for the presence of delirium, and this was done with a standardized instrument. A multi-center cohort study found that 28% of 817 elderly patients at that time met criterion for delirium upon presentation to the emergency department. So these are people that were diagnosed with COVID-19, and they were also exhibiting a high percentage, of them were exhibiting delirium upon presentation. So these individuals definitely would be high risk and could potentially spread infection very easily if they're still in that state of delirium and discharged right from the ED or discharged from the hospital while they're still showing positive symptoms. And this, of course, isn't just true for COVID, but true for other infections as well. For some individuals, there also may be a transitional period in which they're not able to exercise transmission-based precaution behavior. So if you had an individual who's in the hospital and they develop a CBA or just admitted with a CBA, et cetera, there may be a period when they can't exercise these precaution behaviors, but subsequently will be able to. So we have to work through and use certain procedures to monitor them until they are able to participate in this health behavior. Related to that, we can use this again at different intervals in the course of an admission. So if somebody's an inpatient, they come in compromised, but as they get toward discharge, we re-administer the instrument and find that their score is in an adequate range and they're able to participate without us being too concerned about there being potential spreaders of serious infection when they enter different environments. The structure of the inventory. So I'm going to get a little bit into the actual assessment, which I've been talking about now. And I'm also going to use a case description, which I think helps really ground it a bit on my other screen, which I have to pull up right now. So the basic instrument contains domains. There are actually 6 domains, and they were derived from clinical experience, expert input, and existing measures that attempt to predict a behavior interest. And it's very difficult when you try to actually predict behavior. The assessment items of each domain are summated and transposed to a standard score, which becomes a domain score. It's still a little abstract. I will get into it more specifically. And each derived scale becomes a total score, which is at the end is the real risk score, the total score. The 6 domains are cognitive, the actual ability to have focus, memory, ability to have mental capacity to go from one step to another. Neuropsychiatric, is there a psychiatric condition that's present at the time of the assessment? If somebody's significantly depressed, experiencing acute psychosis, et cetera. Physical functioning, are they a full risk? Can they use their limbs bilaterally? Do they have neuropathy, et cetera? Sensory, again, neuropathy would overlap, but obviously auditory, visual, other areas need to be known as whether they're risk factors for this person. Awareness, does the person realize that there are certain things that they're doing could cause a problem? So if you're at a table with a lot of people, are you aware of the fact that if you use somebody else's cup and don't tell them you just used it, you could be spreading infection? So just that a sense of behavior that involves awareness is very important. And there's general behaviors, not doing things that would obviously cause transmission, such as coughing without covering your mouth, or other forms of behavior that clearly could be dangerous or cause transmission of infection. I'm being very, these are very simplistic examples. They're more detailed in the actual inventory. A sample assessment item. So in this case, since I mentioned delirium, I'm going to go right there. Excuse me. Is the patient prone to transient states of disorientation and delirium? And we rated from the Likert scale I'm using is a 1 to 5, where the lower scores are the scores that are more in the risk realm. The higher score indicates that the patient is much more capable and obviously are able to work with behavior that would go along with transmission-based precautions. So again, in this particular item, number 1 would be the low score. Delirium and/or disorientation are prominent presenting symptoms. And number 5 would be the high score, indicating very, very no risk or low risk, no evidence of any transient states of diminished conscious awareness. So in this case, If the patient's perfectly okay, you rate it 5. If the patient's absolutely in a delirium state and really not able to focus, you would rate it a 1. And then, of course, they graded ratings in between. The Tbpi risk description ultimately will have a T-score that'll be the total risk score. And that total risk score will have qualitative descriptions to indicate how capable is this person able to exercise transmission-based procedures. And then specific score ranges will go into those qualitative descriptors. So the qualitative descriptors, again, lower scores indicate greater risk, less ability. So extreme risk would be a T-score of less than 23, and adequate level would be a T-score of 43. T-score is a standardized score. A T-score of 50 is essentially the 50th percentile, and it represents standard deviations, generally standard deviations based upon the population that we're looking at. So they're explanatory in percentages as well. Instructions for rating the inventory. Each TBI inventory item should be rated within the past 48 hours based on observations and chart information. Each item is scaled on a Likert scale that I showed you earlier. It's a 5-point Likert scale with higher ratings indicating less risk. I'm going to go into a case example, but I just need a second to get into my other screens. Bear with me a minute. So I'm using an example which I changed a bit, but this is based on a real case patient. Mr. Lehigh, 82-year-old male retired attorney who was living independently before he was appeared in the emergency department. He was diagnosed with RSV and his second COVID-19 infection. The staff made a decision for a brief medical admission. Unfortunately, he also developed UTI within 24 hours of his admission. He did display transient disorientation and some agitated behavior during his acute stay, which is not that totally unusual, especially for elderly patients who are not used to being in strange environments. But of course, the multiple infections were definitely affecting his behavior and cognitive abilities during his brief inpatient stay. So he was placed on anxiolytics, and ultimately he was given a very low dose of Seroquel HS, which kind of helped him that night and certainly decreased some of the more outwardly disturbing behaviors. So there was a point in the admission where he was pretty much ready for discharge, although he still had positive symptoms for the RSV and the COVID. So he was considered medically stable, and yet he was still a possible risk for transmitting infection to other patients. In his case, the decision of the discharge team was not to have him go right back to his apartment. He was obviously needing more support and care than he could get at home, and they were looking at having him go to a rehabilitation facility, which obviously would have a very high-risk population, typically elderly individuals, not always, but also other people that are at risk, potentially recovering from their own illnesses. Again, we have a medically stable individual who presents a risk for spreading infection in a high-risk environment with other people that are high risk. So in this case, the application of the transmission-based precaution inventory was particularly useful. The attending resident in internal medicine administered the instrument and combined chart information with clinical interview, which took about 10 minutes, the actual interview. And results indicated that he was at moderate risk in the cognitive domain. He was at mild risk in the sensory domain. He had some neuropathy, but otherwise the sensory conditions were good. Awareness was moderate risk. At times, he really didn't know what he was really doing as far as how it would affect other people. And so that's not a good sign. Behavioral domain was mild risk. Neuropsychiatric was mild risk. Physical was within normal limits. And his total score, the total transmission-based precaution inventory score, placed him in the moderate risk range. So, okay, what do you do with that now? You have a patient that's moderately risk for transmitting infection, in this case, he's going to be discharged to a rehab facility, and we know that he could potentially cause a problem. So the discharge plan used the contemporaneous results, and room isolation was initially required, especially until he became negative for his RSV and COVID. Um, Planned neuropsychiatric assessment was planned to go over his medications and potentially go over his overall medication regimen, et cetera, to make sure that there are no side effects and to make sure that they were optimal in increasing his awareness, cognition, and behavior to comply with transmission-based procedures. Supervision of his behavior by nursing staff, by nursing assistants, et cetera, to help follow up on management so that he wouldn't be doing things that could potentially cause infection, especially when he was outside the room in transport, in times when he was going to different diagnostic assessments, et cetera. And psychological consultation was considered for brief cognitive therapy. We focused on his awareness of the environment that he was in and adjusting his behavior. So the instrument led to a high score, a moderate risk score, and there were specific interventions that were put in place with this discharge. They're never going to be perfect, but at least there was an awareness and there were methods that were being utilized to make certain that we minimize the difficulty, the risk that this kind of individual, who well-meaning and all, could cause in another environment, in this case, a rehabilitation facility, excuse me. Okay, so let me go on. This goes through just a bit of what I was talking about. He did recover eventually, and he did become stable. So what we look for is, again, mitigating the risk factors and working with the medical issues until the patient is no longer a high risk for contagion of infection. So, get this to work. For some reason, my screen is freezing. Give me 1 second. I'm so sorry. This seems to be a little technical issue right now.
Yeah, sorry.
Yeah, I just got it now. For some reason, it was my screen was freezing for a minute, so not sure what happened. I want to discuss some contemporary developing new health challenges. So contemporary research is now suggesting that reinfection with COVID-19 increases the risk of developing long COVID-19 syndrome. So post-COVID syndrome, your SARS syndrome. Basically, what's going on, I think, as I look through the literature now, is that there is a definite risk factor for people that have had COVID to develop long COVID and subsequent infections. And of course, the higher the risk groups, it seems to correlate with the higher the risk for long COVID as well. So there is something going on in the international population that is suggesting that reinfection is not a good thing. And as we know, there are enduring symptoms of fatigue, both cognitive fatigue, physical fatigue, sensory loss, certainly continued loss of smell and taste, other factors. And so it does appear that even though people may have been vaccinated initially, and even if they've been boosted, certainly in elderly populations and high-risk populations, there is a risk for reinfection and having long COVID. And I believe that current epidemiological studies are showing about 10% of people with COVID will develop long COVID based on reinfection. It's possibly more than 10%. And in high-risk populations, I suspect it's more. So again, high-risk subgroups remain vulnerable to reinfection. Now, I'm focusing on COVID, but obviously COVID is not the only infection that this can occur through. There are also a number of epidemiological predictive models that have concluded that another pandemic is definitely possible within the next several decades. So certainly within our lifetime, we might actually see something, hopefully not as bad as what we saw, but there can be other pandemic potential infections out there. And even previously eradicated, largely attenuated infections such as measles are reemerging. So we do need to be aware that this kind of contagious need for mitigation by precautions for transmitting infection is very important and will continue to be very important. Yeah. So again, the need for this tool will remain present, and this kind of tool aligns with best practice procedures for healthcare. And because it does have standardized data that we get from using the methodology, future research can easily use its growing database. So my hope and dream would be that there be a lot of samples, a lot of patients that we were assessed with this measure, and that eventually research can be used to see different predictive models, different retrospective models about what this means as far as mitigating infection spread. So I am now open to questions and suggestions. As you can tell, this is a developing instrument. It's at a very primitive stage. I'm still actually working with my app people, and I'm still working with the item analysis and refining things. So we're very much at a stage where there's a lot of development going on, and I'm definitely looking for potential collaborations. I'm looking for collaborative sites, potentially international collaboration, and certainly the ideas from this very esteemed clinical audience. So I'm going to open it up